Hello, everyone. Welcome. My name is Dr. Eliana Ramirez. I am the director of the CARE TA Center. We are the Crisis and Recovery Enhancement Training and Technical Assistance Center. We are here today with our esteemed colleague, Mr. Jamie Seller, who is going to be presenting on Crisis Now, Mobile Crisis Outreach Teams, Staffing and Policies. We are funded through the Mental Health Services Act and the Department of Healthcare Services through the state of California. We are also, several of us, employed by the Center for Applied Research Solutions, and just want to share out that the ideas and thoughts that are shared here today are not necessarily representative of the California Department of Healthcare Services nor the Center for Applied Research Solutions, but we are very grateful for their funding and support. So in 2021, so many meetings that are happening in virtual spaces. We, of course, also need to think about security and just have this disclaimer here that if there were to be a security issue, we would immediately shut down this meeting and the meeting would not resume. We would then send a follow-up email to let you know with further instructions about the remainder of the session. We don't anticipate there should be any issues, but as 2020 and 2021 have been years that have kept us on our toes, we are prepared to be on our toes. So what is CARE? CARE, as I mentioned, is the Crisis and Recovery Enhancement TA Center. We provide training and technical assistance regarding the crisis continuum of care and justice diversion in the state of California. Our primary audience are the MHSA-funded behavioral health programs at the county level across the state. We are very fortunate to be a robust collaboration. We are CARS, the Center for Applied Research Solutions. We are also partnered with RI, Recovery International. That is the agency that Mr. Jamie Seller is here with us today from. We also work with NAMI, the National Association of Mental Illness California chapter, as well as C4 Innovations, Research and Action Center out of Impact Justice, and Stanford Sierra Youth and Families. We provide a variety of services to the field, again, in support of the crisis continuum of care and justice diversion in California. These include a variety of virtual learning events like today's session. We also are gearing up for our very first ever conference. Please mark your calendars for June 16th and 17th, where we'll be focusing on diversity, equity, inclusion, and anti-racism within the crisis continuum of care and justice diversion. Should you go to our website, you will find a variety of resources like a resource library, also an asset map where you can find all of the crisis continuum of care and justice diversion resources and programs that are in your area. You can search by zip code to see what's available at the county level. We hope you'll stay connected to us by joining our newsletter. We send a newsletter once a quarter, as well as being connected to us through social media. And if you should like to request training and technical assistance, please do go to our website and submit a form where we can meet with you to hear more about what your training and technical assistance needs are. Perhaps you need a resource, or perhaps you'd like some consultation or training specifically for your team. Again, please go to our website and feel free to submit a form. So before I introduce Mr. Jamie Seller, who is a collaborator on the CARE TA Center, as you'll hear, because he's done significant work at a national and also an international level, we want to start off by getting to know you a little bit more with a few polls. Does your county have a mobile team? Possible answers are yes, no, we're in the process of designing one, or no, we are not in the process of designing one. This is really interesting. So we're having a large proportion of folks who do have a mobile crisis team. So for our second poll, if you do have a mobile team, what model is it? Your choices are co-responder model, independent model, or other. And we would ask you to please describe the other model in the chat box. Thank you all so much for entering your responses into this poll. It's really helpful for us to get a sense of what your experience and your knowledge and what's going on in your local county. So we've got a number of people who have voted. It looks like we're just around 50% at the co-responder model, 25% independent model, 25% other. And people are adding their answers into the chat box. So we've got wraparound in the chat box. Christina Walters is mentioning that there's a psychiatric emergency room team, PERT, with the sheriff's office. Terrific. Thank you. Please keep those answers coming. We'll go to the next polling question, please. Are you familiar with the SAMHSA National Guidelines for Behavioral Health Crisis Care? These were published just recently in 2020. Just curious so that we can know where we should start off in our presentation today, what level of information to share with you. So far we've got folks answering in. Choices are yes, no, and somewhat. Outstanding. I think that this is a good number of folks. So about 40% saying yes, 40% saying no, and 23% saying somewhat. Terrific. Thank you for that. And I think we're moving to our fourth question, if I'm not mistaken, our fourth and final polling question. This question is, what is your comfort level with understanding how mobile teams should operate under the national guidelines? Your options are not at all comfortable, somewhat comfortable, and we'll make that bottom one somewhat uncomfortable. See, so your choices could be not comfortable, somewhat comfortable, and we'll all pretend that the bottom one says somewhat uncomfortable. This is interesting. So we've got about 60% saying they're somewhat comfortable, 25% saying not comfortable, and the bottom 17% as we reassigned it as somewhat uncomfortable. Thank you so much. So without further ado, it really is my honor and joy to introduce to you Mr. Jamie Seller, who is a behavioral health executive with 25 years of successful experience in running crisis programs in multiple states. These programs have included both inpatient, subacute, residential, mobile crisis outreach teams, hospital rapid response, and mental health urgent care centers. Currently, Jamie specializes in crisis system development, and operational management. In his current role as Chief Strategy Officer at RI International, he consults both nationally and internationally on topics such as crisis system optimization, peer use in the workforce, and program design. Jamie has a long history of training professionals and paraprofessionals on practical client engagement strategies. A licensed clinician, Jamie strongly believes that the rapport between caregivers and those in need is a primary driver of success in crisis work. RI is a global organization with more than 50 behavioral health programs throughout the United States and abroad. RI provides crisis, health, recovery, and consulting services wherein their values and priorities include maintaining a recovery culture, ensuring clinical best practices, making safety a priority for all, measuring value and results, optimizing quality and compliance, and serving as a key resource for first responders. And just on interpersonal level, Jamie is a wealth of knowledge, and you really are in good hands today. Today is the second session in a three-part series about mobile crisis teams. Without further ado, welcome, Jamie.
Thank you, Dr. Ramirez. I appreciate that. So I'm going to actually go a little deeper dive into who I am and why I'm talking here a little bit. You know, what was most interesting about how Eliana introduced me is 25 years of successful experience running and operating crisis systems. I've got about 30 years experience. Obviously, that bio that I had sent to her is a few years old. But it's probably a little bit more accurate. Well, I've got 30 years in the field. I probably do have 25 years of successful experience, and a few years that probably were fairly unsuccessful that certainly have kind of helped develop me to the person that I am today. And I'm going to talk a little bit about all of that. You can see on the screen the agenda, and I'm going to talk a little bit about my personal relationship with the national guidelines as well as mobile teams, a little bit about why I'm here. So I was fortunate enough as an LPC to grow up working within Maricopa County, Arizona. Maricopa County, about 4.4 million people. And while we have issues around a host of social determinants of health and teen pregnancy and alcohol and drug abuse and a host of other things that we're certainly not in the top ranking in any US state, really what we do excel at is crisis services. Excel in crisis services as a result of kind of the reasons why most systems tend to change: lawsuit. You know, lawsuit or money tends to drive system change faster than anything. And in the 80s, in Maricopa County, where I have spent the majority of my career in operations, I've also worked Washington, Utah, and California. The reality is, based on that lawsuit in 1984, we really had to change the way that we were serving people. What we were doing was we were using an institutionalized approach. We were keeping people in our state hospital for months, if not years, just because there wasn't an appropriate solution in the community to go ahead and support them. As a result of that lawsuit, we decreased significantly the amount of state hospital beds that we could use for civil commitment. And as a result of that, we really need to strengthen our crisis system to ensure that people don't get to the level of acuity that's going to require a long-term inpatient stay. Very successful lawsuit. Very glad that it came about. It made the system change that eventually became seen as the model of crisis now. So my background working within the system here is inpatient. I've done outpatient. I've done private practice. I've run mobile teams. I've run residential programs. I've run inpatient programs. I've run rehab centers. I've run a host of systems, but all within the confines really of a longer systemic approach. But what I've spent most of my time doing is working with the crisis system here in Maricopa County. I spent about 5 or 6 years working for an agency called Teros. Teros is a nonprofit here in Maricopa County, operates 23 mobile teams per day that are going out and working in community. And while I was working there, the national standards started to come about. The Crisis Now model started to come about. And we were fortunate enough that Maricopa County was highlighted as a way the crisis systems do tend to work well. And the agency I was working with and the program that I was overseeing was actually seen as an exemplar in the Crisis Now model, which eventually became SAMHSA's National Guidelines for Mobile Crisis Outreach. That was published in 2020. RI, myself included, were 7 of the 14 writers on that. So I'm very intimately aware of what the federal guidelines are saying should be quality professional crisis care. So that's really the slant that I'm going to take a little bit today. So the goal is to learn a little bit more about that. I saw that the poll that we had is that some people are familiar, some people are not familiar. Certainly understand that. It's 84 pages. While it's not a tough read, it's always tough to get that reading in. So we're going to learn a little bit more about that. We're going to learn about the attributes of mobile crisis outreach team members. I'm going to review training, not in depth, but really what the elements of a training program for mobile crisis outreach teams could be, should be, at least the ones that I tended to use. And maybe we're going to understand some of the deeper learnings that I've learned over a career, particularly working in crisis, but really working with those mobile teams. So I'm going to start a little bit by talking about what mobile teams are and what mobile teams aren't. So as we start looking through, what we're going to go ahead and see is the term that's used most nationally is going to be mobile crisis outreach team. I'm going to hear them called mobile teams. I'm going to call them, we see as psychiatric response teams. We see them as SBIRT teams. There's a host of names for this, but really the vernacular that we're looking to use is a mobile crisis outreach team. I've done consulting, I'm going to say probably in about 16 states in the last 4 or 5 years, been in a few continents doing consulting. Mobile team is something that always comes up, and everybody tells me that they have mobile crisis outreach teams, and I want to discuss what that is. So when we're talking about MCOT teams, we're talking about mobile. I mean, so I'm going to get in a van, I'm going to get in a private car, I'm going to go somewhere. I'm not going to be facility based. Most communities are going to have something that's mobile. Crisis, for us, crisis is unplanned. It means a call comes in, somebody's in trouble, I'm going to go out. Most communities have something like this. Outreach is going to be done in community. And team really means that it's a unit, not a program. I've got a 2-person team going out. So on some level, everybody, every community, every county has some form of mobile crisis outreach teams. But the reality is when we're talking about the national standards, we're talking about a very specific standard. I'm going to go in depth and I'm going to hit on a few of these topics multiple times just because I do like the repetition on it. But what we're talking about with a mobile crisis outreach team in the national standard really in general is going to be a 2-person team consisting of a qualified mental health professional, a licensed professional counselor, licensed marriage and family therapist, could be at the associate level, and then generally a paraprofessional. And that paraprofessional is going to end up mostly being a certified peer support specialist or a behavioral health tech or a psych tech, depending on the vernacular. And really what we're looking at a 2-person team that's going to go into community where people live, work, and play. And you're going to hear me say live, work, and play a lot. It's going to go into community with a goal of stabilizing somebody in crisis and allowing them to remain in community without the need to escalate into a higher level of care. If done right, what we'll be seeing with mobile community crisis outreach teams, what we'll end up seeing is a less reliance on police as being first responders for behavioral health or substance use disorders, less of a reliance on emergency departments as a facility-based practice, and really a better opportunity for people to get the right type of care where they need it, when they need it, to be able to remain in community and really start working their path toward recovery. So let's go ahead and move forward. So what I'm going to be breaking down, you can see at the bottom, the National Guidelines for Behavioral Health Crisis Care. I think it was just kind of posted in the chat as well. I thought that I saw that pop up. A best practice toolkit came out in February 26 of 2020. It was really based on the Crisis Now model, which came out in 2016 through the National Action Alliance for Suicide Prevention, which really came out as a response to the 2014 National Strategic Plan for Suicide Prevention, which really talked about access to care as being a #1 driver, at least one of the top 4 drivers of why people are dying by suicide at increased rates over the last 25 years. And we've seen increase in suicide rates don't correspond to the other 9 leading causes of death in the US, which we're kind of bending back. So when we talk about the national guidelines, mobile crisis team services offering community-based intervention to individuals in need wherever they are, including at home, work, or anywhere else in community where the person is experiencing a crisis. So with the national guidelines, there was a real specific focus to identify what is crisis and what isn't crisis. And we came on a couple of different topics or a couple of different ways to go ahead and define that. True crisis services are services that are willing to work with anyone, anytime, anywhere. So if we take a look at how first responders and emergency departments tend to work, a fire department's never going to say, that fire's too big for us to go ahead and handle, we're not going to respond. Police are never going to say, I'm not going out on that particular call because somebody's going to go ahead and be too violent. But what we do often say in services that are designed to be crisis, that person's too acute. That person has too much aggressive behavior. That person is going to take too long to respond to treatment or intervention. So if we are providing a service that is going to have qualifiers or exclusionary criteria, it's no longer a crisis system or a crisis service. So what we focus on within crisis now are 3 elements of care, one of which is going to be the crisis call center, which is going to pick up the phone every time it rings, or at least should. Community-based facilities that are going to accept everyone, regardless of their voluntary status or whether they're intoxicated or not. But with mobile teams, what we're really looking at is the model that's utilized here in Maricopa County, the model that's utilized across the state in Georgia, which means anybody, anytime, anywhere that needs a mobile response is going to get that. So here's how I start to differentiate a true mobile crisis outreach team from one that isn't. I'm going to start looking at exclusionary criteria. So as I've said, I've worked in about 16 states in the last 4 or 5 years here. And what I do know is the majority of the mobile teams that they have will have exclusionary criteria on who they'll see and who they won't see. They will say things like, we won't go out anywhere if the person is intoxicated. You know, the belief underlying that is how can we do a level of care assessment, or how can we engage with somebody who's got an altered state of consciousness because of the chemicals that are on board. We can't really do a good assessment. They're difficult. We'll wait until they're sober. We're going to make a referral to the emergency department, then we'll go see them in the ED, 12 hours from now when they're sober. Or what they'll say is, we're willing to go see anybody as long as they're the ones that made the original call. If they called to the call center and said, I'd really like Jamie and his mobile team to go ahead and come on out, then we'll go see them. But if I'm calling for my friend and say, I think my friend's in a dark place, I really need some support for them. He's not willing to get on the phone right now, but can you send a mobile team out? A lot of times mobile services across the country will say, no, that person needs to actually request it. So once again, if we're looking at crisis service and a definition is anyone, anytime, anywhere, as I start putting roadblocks between me and serving the general community, I'm really moving further and further away from crisis. And really what I'm saying is that a response probably is warranted, but somebody else should do that. And I know it's a behavioral health crisis, but I think there should be a police response out there to go ahead and talk to that person that's currently intoxicated or has a little bit of agitation with suicidal ideation. Or I believe the best facility for that person is going to be an emergency department where they can go ahead and do medical care, and then we'll start to assess their behavioral health issues after they start to sober up. So I really want to talk about the national guidelines being anyone, anytime, anywhere. And as you start to think about your current system, think about what exclusionary criteria you have, what roadblocks you're putting up between you and the community to go ahead and be able to serve. And are those legitimate? Are there ways to work around that? Are there ways to improve access to care for folks? Because once again, what we do know is the tougher situations that we deal with, increase in death by suicide, really does have a direct correlation to inability to access care at the right time in the right place. So what I'm going to talk about in the national guidelines, really there were 2 expectations that were created. One is, what's the minimum expectations to operate a mobile crisis team? What are the minimum expectations? And one is I need a licensed person. I need a credentialed clinician that's capable of assessing the needs of individuals. Part of the reason that we're going to look for that is from a funding viewpoint, I do need a licensed clinician if I'm going to go ahead and get Medi-Cal reimbursed or if I'm going to get Medicaid reimbursed. But I need somebody who within their scope of practice can go ahead and do the risk assessment, the treatment planning option, the coordination of care, all of those kind of things. Well, we really talked about the operation of a mobile crisis outreach team, and a minimum expectation is that they need to respond to where people live, work, and play. So often we see those mobile crisis outreach teams have limited scope in where they go. We go out to see people, absolutely. We'll see them drunk, we'll see them involuntary, Jamie, no problem. But we only do our level of care assessments at the emergency department, or we'll only do our level of care assessments at the jail. So really what I'm doing at that point is I'm not doing a community-based response. If I'm going to the emergency department only, certainly providing a valuable service. But that valuable service is to extend the professional staff of the emergency department. And what I do know is that by the time somebody hits the emergency department for a behavioral health primary case without a concurrent medical issue, the system's a little bit broken. It's expensive. We know emergency departments are not the best place for someone with a behavioral health or psychiatric crisis. We do know that we get better results when we actually meet people in their homes and their communities, places that they start to feel comfortable. And really what the minimum expectation for a mobile team, minimum, just bare minimum, is to connect individuals to facility-based care as needed through warm handoffs and coordinating transportation when and only if situations warrant transition to other locations. So it's taken in context of the whole thing. Really what we're looking for in a mobile team is we're looking for a professional that's able to go out, respond in community, assess, stabilize, allow people to stay in community where appropriate, and if not, to connect and coordinate them with care. I'm going to say 3 years ago now, I was working in the United Kingdom. I was working in London, and they have a term called street triage. So their mobile teams are called street triage teams. I like that and I don't like that. What I do like about that is it tells you where they're working. They're working in the street, where people live, work, and play, where people are in crisis. I've got a community-based response working in the street. I didn't like the triage component of it because that just says I'm really doing an assess and refer model. You know, if it was street stabilization, it'd be a little bit better, but I do like the term street because we often start thinking the only place that we can do this type of work is in a secure locked facility, i.e. an emergency department or an inpatient program. We really need to be getting out there in community and supporting. So as we start thinking a little bit more about anybody, anytime, anywhere in community, you can start to see that it can be real effective, but also there may be some barriers and some concerns about that as well. Hopefully we'll talk through that. But if we're talking about full fidelity, really what we're talking about at that point is a two-person team, qualified mental health professional, LMFT, LPC, and a paraprofessional. And I do get a lot of pushback when I use the term paraprofessional because peers often are acting very professional, whether they're out there in the community. But really what we're talking about is someone who's certified versus licensed, someone who has a more limited scope of practice and inability to legally go ahead and do assessments and diagnosis and so forth. But the reality, what we tend to see is those mobile crisis outreach teams that get the best outcomes, strongest fidelity of the key performance indicators, do incorporate two-person teams and do incorporate peer support, which really are engagement specialists out there in the field. Now, there's a couple of reasons why we like to incorporate peers with crisis mobile teams. One is it does increase safety. I've got 2 staff versus 1. Quite frankly, I'm a big, large guy. And when I was younger, I probably wouldn't be too nervous going to parts of South Phoenix by myself. But the reality is I'm a little bit unique. I'm a little bit bigger than your average bear. I wouldn't expect most people working a mobile team to be willing to go into certain parts of certain towns, certain situations without another staff. So what we've seen is when you incorporate a 2-person team, you tend to improve your safety. You tend to create comfort level in your team, and you're willing to go places without police support much more often. The second thing that we look at for utilizing peers on the teams is it gives me a second person to engage the person that's in crisis. So what we do know is probably one of the strongest interventions or strongest predictor of whether an intervention is going to work or not is going to be the therapeutic alliance that we have with the person that we're serving. If I can engage with them, if I can develop that rapport that's going to help drive the rest of my intervention, I'm probably going to be successful. If I can fail to establish rapport, I'm probably not going to get very far, even if I'm technically proficient, have what's in the best interest of the client that we're serving, and know all the community resources. So what we've tended to see is when I put a professional counselor and a professional peer, certified peer support specialist together, between the two, somebody's probably going to be able to engage that person that's currently in crisis. The next goal for full fidelity into the model is going to be to respond without law enforcement accompaniment. So I'm going to say maybe a little bit tough for those of you who are operating a co-responder model. And that co-responder model means social worker or clinician and an officer are going out and they're going ahead and doing good work out in the field. I think that can be incredibly rewarding. You can get great outcomes. What I can say is the national guidelines is trying to avoid the connecting an officer into a crisis situation. Uniforms can be triggering. Introducing a gun into a situation on the side of an officer can be a little bit triggering. Sometimes officers do have a different training background or different goals as far as community safety out there. So sometimes it's a little bit better to really provide a behavioral health response for someone who's in a behavioral health crisis. But what I can tell you is over the last decade in Maricopa County, what we have seen is about 3% of the time that a mobile team needs to go out onto a call, that a co-response is warranted. Somebody's out there that is demonstrating that there is significant danger in that situation. But what that does mean is about 97% of the time, it really is appropriate for a mobile team, that two-person team, to be out there in the field. So if we take a look at CIT International, and many of you will know what CIT is, it's that crisis intervention training. CIT International actually advocates for this particular type of response, behavioral health versus that co-response model, because A, it's cheaper on some level. Officers' time and putting them in does become expensive. You can get a lot more bang for the buck by having behavioral health professionals, but they also realize that the primary role of law enforcement is public safety, not behavioral health care. Giving behavioral health professionals the opportunity to go ahead and impact care in the community with the training that they have certainly beats 2 weeks of training for an officer in mental health or CIT. What we do believe is that for full fidelity, there should be partnership around dispatching for mobile teams. So in Arizona and in Georgia, the method of dispatch for mobile teams is going to come through the call center. There is low barrier. If somebody calls the call center and says, I need a mobile team's generally going to roll. If the call center operator, the clinician on the phone, feels that a mobile team is the appropriate way to go, they're going to go ahead and dispatch a mobile team. What we often see is that there's confusing rules about who's dispatching, when they're dispatching. Are they calling a pager and getting a call back? Are they trying to call a lead clinician who may already be in intervention? Well, we do believe there's ways to streamline that utilizing the technology that's available. What we also do believe is that the ability to schedule outpatient follow-ups and have what we would call warm handoffs in order to support connection to ongoing care. So we've been out there. We want to make sure that people are connected. Crisis work is a time-limited event. We're not doing crisis work for 7 months with somebody, doing crisis work in a mobile team for 75 minutes to 90 minutes on average, but we need to get that person connected into care. So when we start having that two-person team, when we start doing street triage, working with anybody, anytime, anywhere, limiting the role of law enforcement as caregivers of last resort, having a centralized, organized way to dispatch and track the services that we're providing and the care that we're providing, and really able to, when we do community stabilize people, connect them with community. That's really the goals of what mobile crisis outreach teams should be doing. And if you can do that, you're kind of hitting those full fidelity requirements under the national guidelines. And as the national guidelines were created, we understood that if we made them too restrictive to begin with, that it would be difficult for counties or communities to go ahead and start to adapt to them. That's why we did have some minimum standards, some full fidelity requirements, and there's probably even a few advanced requirements that we could talk about during the course of this care. So I want to talk a little bit about an intervention timeline, and I won't talk too much about this because I'm going to show it to you in a different level when we talk a little bit about training. But these are basically the things that you're going to be doing in an intervention out with somebody. What I really want to focus on is kind of that de-escalation resolution. So you heard me mention a little bit previous, how long does an intervention take? In Maricopa County, in Georgia, which we think are kind of the exemplars for some of these services, these people have been doing it for a while, getting pretty good outcomes, pretty well respected. An average intervention may be 75 minutes to 90 minutes. Frequently, I go into communities and I find out that their mobile teams are spending 45 minutes on average doing their intervention. That could be appropriate. I've certainly done interventions in 45 minutes or less. I've certainly done interventions in 4 hours or more. But the reality is, if my average time on scene is about 45 minutes, chances are I'm not really looking to de-escalate or get crisis resolution or get stabilization. Chances are what I'm doing is assessing to see what appropriate level of care somebody needs, and then spending some time getting them into that level of care. But what I do like with this particular model in front of us, and this is directly from the national standards, I need to do my triage and screening. I need to assess, usually a biopsychosocial assessment, see what else I'm seeing. I'm really looking at stabilizing that situation. I'm looking to provide support and intervention at the peer model. I'm going to coordinate with community resources to ensure that I have an adequate discharge plan, care plan, ongoing plan, safety plan, and I'm going to do crisis planning and follow-up as part of that intervention timeline. So these are really the elements of a good intervention out there in the street. But what you may find is that you're kind of maybe not doing a ton of that. You know, you may be doing 4, maybe doing 5, you may not be doing all 6. And in a second, I'm going to actually talk to you a little bit about a 7-stage model that Roberts has for it. So I'm going to talk a little bit about the training. Probably could show you the book, but you know, training as mobile teams is very unique, important. What we do tend to see is that the skill set of your mobile team members are going to truly drive what the long-term outcomes they're going to have. So I do know that some of you said, I'm somewhat comfortable with mobile teams. I'm not comfortable with operating mobile teams. I'm very comfortable with operating with mobile teams. So really what I'm going to talk to you about is how I used to train. And when I say I, the agency that I worked with, what we kind of trained and how we developed and how we adopted over the 5 years that I were there. But as I kind of broke down our training manuals, really it came into one of 3 areas. It was either agency specific, which everybody in the place is going to go ahead and get, or it's going to be a little bit more around crisis theory, getting people kind of mindset how to go ahead and do crisis work, because we get a lot of folks coming to us with, you know, the right education, but not really comfort levels in crisis work, or we get a lot of peer support specialists that have been through their training as a peer, but they haven't fully learned to adapt to crisis as well. And then we actually start getting into some real mobile crisis outreach team specific. So I'm going to talk a little bit about those levels of training as we go through. So let's go ahead and kick it over to agency specific training and see what we're talking about. So these are the things that you need everybody to have for your agency before they even come into the crisis department. There are going to be issues, or there are going to be topics such as HIPAA. I need to know that staff understand legal regulations, some of the risks, some of the ethical considerations that are going in. I need my staff to be able to perform in a culturally competent way. I need them to know what the HR policies are, just as far as time off and all of those things. Generally, I'm going to need everyone to be first aid, CPR certified, especially if there's state regulations around there. I'm going to do workplace violence. Now, you may say that there's 15 or 20 things that your agency does for everybody. They've got to get through that. In a lot of agencies, this may take 2 days, 1 day. It may take a week, depending on your HR department, how many policies they want to run through. But generally, I don't like seeing folks in the crisis department until they've been through the agency-specific training. Because what I don't like is talking about crisis and then talking something as esoteric as how to work the payroll system. I like them to be able to be focused once they come to me, that they have all of that under their belt. So at our agency, the agency-specific training could take up to a week. And really what I was saying is, let me see them after that week. So let's go ahead and move forward and talk a little bit about crisis theory. So, you know, the old rule is that models are a dime a dozen, but you need one. And I think that's true. So at Taros in Maricopa County, really the model of intervention that we're teaching would be Robert's 7-stage crisis intervention model. I think it's as good as any of them that's out there. It looks an awful lot like what those national standards say around what the intervention timeline should look like. There's others. You could learn critical incident stress management. We certainly would teach our staff critical incident stress debriefing, which is part of critical incident stress management. So I'm just going to give you a little exposure to a model. So this is Robert's 7-stage crisis intervention model. And the reality is, I think it's a little bit like Elizabeth Kubler-Roth's model around grief. These are kind of the stages you do. I'm not sure I'm always convinced that these are the stages in order, but you generally tend to hit these things. So number 1, I'm going to plan and conduct my crisis and biosocial assessments. I'm going to find out a little bit what's going on. 2, I'm going to establish rapport and rapidly establish a collaborative relationship. If I was changing this, if this was going to be the Jamie 7-stage crisis intervention model, I'd probably have number 2 as number 1. But what I'm then going to start doing is identify my precipitating event, which in 3 is going to be what was the last straw. What made today the day that you called for crisis services? Probably could have called 2 weeks ago. Life probably wasn't great for you. You might have been able to hold on another few days. What made today the day? Because knowing what my precipitating event is really going to start to drive what my intervention is going to be, especially if my goal is to help stabilize and keep somebody in community. I'm going to explore the feelings and emotions. I'm going to do a little bit more deeper dive. We're going to generate and explore alternatives, including untapped resources and coping skills. I'm going to develop my plan of action. I'm going to get my follow-up plans, my safety planning, my agreement. I'm going to start closing up shop and either taking somebody to a facility if I don't believe that they're stable, or getting them a good safety plan and discharge plan of where they're going to go next if I believe that I can stabilize them in community. Crisis theory, I think there is good, but then there's also some crisis-specific theory that we want to talk about. And I'm not going to endorse any one of these over any other. But what I will say is that we've used all of these. I've seen all of these used across the country. I think you need that. Assist training for mobile team members, I think, is important. 2-day training gives people an idea on how to talk to those folks that are suicidal. Firm believer in Dr. Thomas Joyner's interpersonal theory of why people die by suicide, which really has a strong emphasis on people's feeling of perceived burdensomeness and unwanted aloneness or kind of forced isolation. Generally, if you can start to remove some of those beliefs and feelings from somebody, you generally are working a little bit well. Zero suicide in healthcare, which talks an awful lot about how to go ahead and keep people safe within a healthcare setting. I need to teach people about SUD. 70% of the folks that we see in Maricopa County are going to have a substance on board while we're interacting with them. I need to know a little bit about how that's going to impact my intervention. I need to know when somebody might be going into withdrawal, because my evaluation of my final placement for that person may change depending on what the potential for withdrawal is going to be. I also need to know about ASAM placement. I need to do trauma-informed care with SUD. Also, specific crisis theory training I'm going to do is on risk assessment tools. So I'm going to talk briefly just about evidence-based practice and some of the things that we do. I would say that less than 50% of the mobile teams that I come out and evaluate and check while I'm doing my consulting utilize a standard risk assessment. Often they're going to be utilizing risk assessments that they've kind of created, that a clinician's created, that they've kind of used at their system since the 80s, the 90s, or for the last 10 or 15 years. Easy to work with. We like it. We trust it. Generally, what I'm going to say is for mobile teams, you want to have as much of an evidence-based practice cabinet of tools as you possibly can. So I personally do like the Columbia Suicide Severity Rating Scale. When I was running mobile teams here in Maricopa County, that became the standard. It was utilized on everybody. It's quick, it's easy. It does give some opportunity for some clinical interpretation, but when used as part of a complete breakfast, when used as kind of the entire picture of somebody, it helps to inform the decisions that you're going to make to ensure that there's a logical progression and how folks are going. So once again, I do want to come back to working in crisis means that every person that you talk to has a potential for an adverse outcome if you don't do work the way that you're supposed to do. Using those evidence-based practices decrease the risk of those adverse actions. They also protect you in the case of those adverse actions around litigation or potential problems down the road. So all of these are good certain risk assessment tools. I do like the Columbia Suicide Severity Rating Scale. It's absolutely free to use. It's probably the more standard one across the country. Dr. Posner, who created it, makes it very easy to use. It's absolutely free. Training isn't that difficult to go ahead and get. People can get up and running. But once again, you can use a Beck scale and some of the substance use things you can use, the TAPS-1, the TAPS-2, screening and brief intervention, or the S2BI, ways to go ahead and go. So what I would recommend is that every mobile team intervention you have utilizes some risk assessment tool that has an evidence base behind it. I would also recommend that every time you guys do an intervention, that you use some kind of safety plan that's got evidence base behind it as well. Obviously, we're talking about training, so we need to train to those. Stanley Brown is probably the more comprehensive in the US safety planning tool. Connecting with people is used in Australia and the United Kingdom. Recently, I've actually developed a program in South Australia, Adelaide, and when introducing the Stanley Brown model, they actually moved away from the model that was currently in use in South Australia towards Stanley Brown. I think it's probably one of the best in the world, if not the best in the country. Certainly a lot of research behind that. Also, there's an opportunity. Some states, particularly Georgia, has a heavy reliance on the level of care utilization system, which really is a patient placement tool. It's 6 dimensions. You get a score at the end of between 1 and 6, and depending what your number is, it tells you where you need to be. Probably the best analogy to that is ASAM placement criteria, but this is more for behavioral health. We utilize the locus because it is evidence-based. Probably not the best tool that we've ever seen, as far as there's a lot of little things that make it a little bit difficult. But once again, as part of a comprehensive screening and decision driving process, when I've got a risk assessment tool, my safety plan in place, the patient placement tool, and my clinical decisions, I'm probably making a pretty good decision on what I need to do with somebody. But once again, these things all then need to be trained. They need to be applied. They need to be reviewed. You need to watch people be able to do that to make sure that they're applying it well. So these are some of the crisis theory training tools that we would have if I was starting a program in your community. So the other thing that we want to focus a little bit on during that crisis theory training is going to be population-specific training. So I'm working currently with Oregon, and the big question right now is, should we have specialty teams? I think it's a very legitimate question. Should I have one mobile team that exclusively works with children and adolescents? Should I have a mobile team that works exclusively with veterans, or a mobile team that works exclusively with those that might have an intellectual and developmental disability? And I think the reality is, if you've got a large community and you've got a lot of mobile teams, having a few specialty teams is great. So in Maricopa County, we're running 23 mobile teams a day. We do have a child and adolescent team. They're going out to the schools predominantly, 8 hours a day, 10 hours a day. They are specific developmental for children and adolescents. We've got a specific team that goes out that works with folks with intellectual and developmental disabilities as well. But we've got 23 teams. The other 21 teams are going to be generalists. They work with everybody. They might work with a 9-year-old. The child and adolescent team is already on a call. They might work with a 92-year-old. They might work with someone with intellectual and developmental disabilities. So what I can tell you is we start thinking about your communities. What we do know, or at least what our algorithms and kind of our data modeling shows, is that if you've got 100,000 people in your population, you're going to have roughly 769 to 800 times per year that you need a mobile team to go ahead and roll. So you can start to see, if we're going out 2, 3, 4 times a day, it becomes cost difficult to go ahead and have one team that only goes out on one certain part of the population. So what generally is going to end up happening is you're going to have generalists. You're going to have your teams need to be trained in anything, because that phone's going to ring and something's going to happen. So some of the population specific trainings that we would offer, and we would suggest that you would think about offering, would be grief and loss, working with the homeless, working with those that are psychosis, a little bit separate subset, maybe those that are first episode psychosis, specific training on how to work with people with relationship issues, health issues, veterans, LGBTQ, clinical skills across the lifespan, working with children and adolescents, also working with geropsych, because you're going to get a lot of folks that are calling in a crisis, and really what you're dealing with is dementia. It's a little different beast. Those with intellectual and developmental disabilities. We also talk a little bit about interventions. We're going to talk about how to develop that therapeutic alliance and rapport. The model that I utilized, and I don't know if any other program that's utilized it, is AIDIT. AIDIT stands for Acknowledgement, Introduction, Duration, Explanation, and Training. It's a model that I actually use with phlebotomists and ER nurses to teach them how to rapidly develop rapport with somebody to help them move them through the process. I think it was very initially strong with phlebotomists because people have a lot of fear of needles. But if they engage somebody right, they're going to decrease that. Works very well for establishing rapport quickly with somebody who's in crisis. So I would teach how to develop rapport. I've mentioned before, it's a primary intervention. It's going to be my primary driver of a successful intervention. If I've got teams that don't know how to engage, don't know how to develop rapport, don't know how to develop a therapeutic alliance, I'm not going to get quite the outcomes that I'm looking for. I also want to teach skill and coping mechanism building. If we're doing stabilization, there's a lot that we need to teach the clients out there. I want to give our staff a skill set that they can actually work with a wide variety of issues and help people come up with solutions and find ideas to resolve their presenting problem, the reason that they call today, because that's really what the goal of stabilization is going to be. So basically what we've done is we've talked about the agency requirement training. You got to know what the vacation days are. I've got to know how to call off for a shift. I need to know all of those things. We talked a little about crisis theory. Kind of a little bit more of the esoterical. Let's go ahead and give you the background, because what I do know, even if you're a licensed clinician and you go back to your training in your master's program or your PhD program, the amount of time talked about assessment and suicide assessment and engagement, it's not there. I'm a master's level clinician, graduated in '93. I learned more on the job than I did in that degree. But once we get through all of that, we really need to start talking about mobile crisis outreach team specific trainings. Some of the things that we're going to work within the system to get our folks up and running. So I need to teach them the basics, the daily operations. I need to teach them how they're going to go ahead and be dispatched with the protocols coming in. I need to teach them how to chart, what's important, what's not important. I need to teach them how to be working within our electronic health record, what documentation means, what it doesn't mean. I need to teach them how to log out a van. I need to teach them how to fill the van and how to use the credit card to go ahead and fill the van if they're running on empty. I need to talk about what their supervision requirements are going to go ahead and be. So really, these are kind of the nuts and bolts, logistical things that are out there that we're really trying to teach. Just the day-to-day operations of how mobile teams run. But also what I need to do is I need to really give them a lot of tools in their toolbox so that as they're out there in the community and they're thinking about what my final disposition for this particular person is going to be, the more that they know of the community resources, the more likely they're going to be able to find one that's going to work for somebody to allow them to remain in community. So I need them to know what facilities are available for the services they might need, what outpatient programs are there, what timeframes they have to get into some of those outpatient programs, support groups, a whole host of issues, respite levels of care. We might need to know about same-day access outpatient clinics, where they can get their pharmacy needs met at 2 o'clock in the morning. Really what we spend a lot of time is developing, refining our community resource books, and then training to that. And then every 3 months, making sure that all of those agencies are still doing what they're supposed to. So if we look at Maricopa County, which is going to be a little different than probably the communities you're working in, Maricopa County's got 9,600 square miles. So it's big, it's physically big. California does have some big counties as well, absolutely. We've got 4.4 million people. You guys have some counties that big as well. But if you think about, I need to know on the east side of the county what the resources are there and what the resources are in the west side of the county, and realize that a company may go out of business in a year and we don't hear about it, and I'm making a referral. So you constantly have to renew what your community resources are, and you constantly need to train to that as well. These are some of the mobile crisis outreach team specific trainings that we would have as well. One is a training on personal safety. So think about that term street triage. We're working where people live, work, and play. We're going to teach staff how to approach a door. We're going to teach staff, where they're going to want to sit in a room, how they're going to want to approach, how they're going to want to deal with dogs. We're going to teach them personal safety around how they're going to go ahead and drive, when they're going to be alone with a guest, which is generally never, or a client, which is generally never, how to go ahead and use the van for personal safety. We're going to host, it's about an hour conversation that we would have on how to keep people safe out there in the street. The confluence with law enforcement we're going to talk about, because the interaction with law enforcement and mobile teams is often, like I said, about 3% of the time there's a co-response needed. But what we see here in Maricopa County is about 10% of the calls that mobile teams are going to go out on was initiated by a law enforcement officer who said, hey, could you come out to scene and take care of this? So there is a lot of interaction with law enforcement. And really what we want to also do is we want to start training on when to bring in law enforcement, how to interact with law enforcement, and what the role of each is going to be in a crisis intervention. We're going to teach when and how to get supervision, when to make that phone call to your supervisor, when that supervisor is going to make a phone call to the chief medical officer or psychiatrist. Team dynamics, roles, and scopes of practice. I want to make sure everybody knows what their role is, that they're doing what's within their scope of practice. But we'll talk a little bit about that partnership between a clinician and a peer. And one of the primary goals of supervision around that, transportation guidelines, when we can put somebody in the van, when we can't put them in the van. And we're going to do an awful lot of work around self-care. So these are some of the specific trainings that you can think about. Am I hitting these as I'm getting new staff up and running? Am I making a concerted effort to go ahead and talk about the importance of self-care, the importance of personal safety? And once again, we talk about supervision. I'll talk a little bit more about personal safety because it becomes a big issue in street triage. So I can't tell you a standard training timeline. I don't think there is one. I don't think there's quote unquote a national standard. I'd love for it to be operationalized. So I'm only going to tell you what I did. Really, it was 3 weeks of the crisis theory, the mobile crisis outreach specific training. I would consider things like ASSIST, which is a 2-day training, AIDIT, which could be like an all-day training. All of these things I did once I got somebody into my department after I got them through from HR. It was about 3 weeks of crisis theory and that MCOT specific stuff. What I then would do is I would put them on a full team. So if this is a clinician, they're going out as part of a team, but they're the third person on that team. There's a licensed clinician, a veteran, usually kind of a training officer, someone who's been there that's able to go ahead and train a new clinician coming in, probably some of my best and brightest, best outcomes, but they're shadowing a team. And after that, really what I would have them do is, okay, you are now the clinician on the team, but I'm having that really good trainer actually shadow you, making sure everything's safe. So by the time they're going to work independently out there in the field, they've probably got 6 weeks of on-the-job training, seeing how it's done, working through a lot of those issues. I do the exact same thing for peers, except the difference is going to be is the peer on that team then is going to become that training officer. But I'm going to do 3 weeks of them shadowing, 3 weeks of them being shadowed, And then what I'm going to do is I'm going to make sure they're getting a lot of supervision, that every case is discussed, that we really talk through it. Any points of discomfort or disagreement gets processed. And really what we're doing is we're giving increasing responsibility throughout that point. And at the end of that 6 weeks, the training officers and the supervisors, they need to make a decision whether or not this person's ready to be a part of that team as just a 2-person team. So from an operational viewpoint, I make sure that they were getting a monthly evaluation every 3 months, which kind of means that they're getting an evaluation before they actually start working independently. So they get 3, and then I do usually 2, 1 every 3 months for the first year. And then after that, usually it's annually. I'm doing an annual supervision or an annual evaluation, unless there's an ad hoc reason to go ahead and do that. Now, really what I'm trying to do from a supervisor viewpoint is check in with those teams every day. Now, they should be getting a lot of feedback from the team that they're shadowing or the person that's shadowing them as part of that team, but there's nothing that replaces that hiring manager, that firing manager of really doing some of that supervision to check in where folks are. So I want to talk a little bit about the training timeline, because as you guys are thinking about staffing models, something becomes readily apparent to you. I can hire somebody, and even if I hire them, they're going to give 2 weeks notice to where they're working. They're going to come see me. They're going to then get a week of HR through the corporate office. And then in reality, I'm going to do 9 weeks of training before I'm ready for them to be out. Now, no staff is ever going to give you 2.5 months of notice. I'm leaving in 2.5 months. Let's get my replacement up and running before I get out. They give you 2 weeks notice, and then you're always running short. So we're going to talk a little bit about how do you create a vibrant pool of staff, and how you keep your folks from burning out or compassion fatigue, and how you kind of keep people in the rotation. So the biggest stressor I have found running mobile teams isn't the actual situations my teams run into in the field. It's, are my slots filled? Do I have open positions? Do I have a plan on what I'm going to do if somebody gets COVID, or if somebody decides that today's their last day? So that training timeline, absolutely imperative. But once you've invested 2.5 months in training somebody, it really is imperative to ensure that you keep them. You can't have a 30% turnover rate and keep your sanity. Part of the reason I don't have a lot of hair is working mobile teams and just pulling it out. So I want to talk a little bit about supervision, because the number one way that you keep staff from getting burned out is through supervision. It's through support. Crisis is an interesting beast. For those of you that are working it, probably would tell me the same, is that not everybody who works in behavioral health is geared or likes working in crisis. There's a subset that love working in crisis, can't imagine not working in crisis, but that's probably fewer than 50%. But my experience has been running mobile teams is people are going to stay with you for 6 months, or they'll stay with you for 6 years. The reality is, if they have a little bit of an attention deficit, they like the fast pace, they can't be confined to an office. They don't want to look at spreadsheets. It's not so much about the documentation. It's about that interpersonal engagement. They like a little bit of heat, a little bit of adrenaline is a good thing for them. Those are the folks that will stay working in crisis for their entire career. I could identify dozens of people that would never move away from crisis. That's where they're going to go ahead and be. But there is a percentage of folks that aren't quite at that level, but they will stay for a long time in crisis, provided I give them the supervision level. So the role of supervision in my mind is a couple of things. One is I want to increase their skill level. There is a huge difference between crisis workers as far as the outcomes they get and their skill set. My goal in supervision is to identify ways that people can be a little bit better in what they do, give them a little bit of support and encouragement, and develop their skill set a little bit stronger. Somebody who's been working in the field for 6 years may approach something a little bit different than somebody who's approached for 6 months. I want to process the interventions that they've done, the outcomes that they've gotten, the decision processes that they have. I know that you talked about, or I know that you talked to 20 people last week in your 5-day shift. What was the most difficult one? What was the easiest one? What was the one that had you scratching your head? Tell me how you thought a little bit about that. This allows me to see into my staff's thought process, and I can see if there's problem areas, or I can see if they're thinking about things clearly, if they're able to use good clinical judgment. But the other thing that I'm constantly doing as I'm having these interactions is I'm assessing readiness for work. So the reality is that when you're working with people who are frustrated, when you're working with people that are sleepy or hungry, you immediately know that the intervention you have with them is going to be a little bit more difficult. If you are working with somebody who's had recent loss or marital trouble, you know that the work that you're going to put in may be a little bit more difficult. But frequently, our staff are going to be hungry and tired and had recent loss and are going through marital issues. Are they ready to work? Are they ready to give 100% out there in the field, which is required? Or are they operating at 80%, 50%, 60%? So one of the things that's always uncomfortable to do as a supervisor, I've got to make sure that my staff are ready to work. If they're not, I need to come up with some solutions. So there's obviously different types of supervision. The most common I see out there is generally going to be one-to-one. I think that's absolutely important. I think it's a requirement. You really need to have one-to-one interventions with your staff for them to feel safe, that they can talk about the difficulties or the challenges they've got. Frequently, though, we're going to see that the primary problem that is brought up in supervision, or one of the more primary problems brought up in supervision, is concerns about the partnership itself. They're not getting along. They're disagreeing about outcomes. They're fighting. They don't like each other's personalities. Sometimes you need to do partner supervision to help people get where they need to get to. And at some point, once a month, once a quarter, it's always good to get the full team together to go ahead and do group supervision so we can talk about changes in policy, procedures, new ideas, common problems that are coming through, and making sure that we're all looking at things in the same way. So while I don't do full team all the time, we would do town halls once a quarter. We would bring everybody in, and I would need to do that maybe 3 times because I've got day, evening, and overnight shifts to get everybody through. But that's where I'm really rolling out new initiatives, giving the attaboys and the kudos that people are going to go ahead and need, really trying to build some of that team. So these are some of the things that I wish I knew day one. What I will say is the most common issue brought to supervision that I've seen, you guys may see others, is about team dynamics. Once again, when you're running 23 teams, there's a lot of team dynamics. If you're running maybe 3 or 4 mobile teams and the people have been working together for a while, you may not be seeing that. We're talking about a co-responder model as well. The dynamics between the officer and the clinician become paramount. So just be ready for it. Don't be scared of it. It doesn't always mean that I need to separate team members. More often than not, it can be worked through, but it's something that needs to be addressed. One thing that I did find out fairly quickly is when we're talking about compassion fatigue or burnout is how staff were utilizing their PTO. So if I had staff that were constantly under 16 hours of PTO because the second they earned it, they'd use it. Those are the ones who are having a lot of difficulty, a lot more burnout. Conversely, those folks that never used their PTO often were burned out because they weren't practicing good self-care. You know, they started to think that I need to be there or everything's going to fall apart. So their PTO would start getting up and up and up and up. And once again, one of the roles of PTO isn't just as a means to go ahead and hire people and tell them what your good benefits you've got, is to make sure that they're continuing ready for work. So I would constantly, at least once a month, twice a month, take a look and see where all of my staff were on PTO. And I would have folks that literally had 3 hours left and they'd been there for years. And I'd have folks that might have 300 hours. Both of them are going to be an issue. So there's a fine line between supervision and counseling team members. So if we're talking about readiness to work, I need to know if someone's emotionally ready to work. So sometimes the conversations may be a little bit more touchy-feely than what you would see in a normal work supervisor relationship. There's obviously a fine line, and I don't want to cross that line and become somebody's therapist. I don't want to cross that line and have an HR issue because I now no longer have boundaries. But know that you're going to be walking constantly that fine line of checking in, seeing how people are doing. Are you ready to work? What's stressing you out right now? Are you able to give 100% to the folks that you're serving because they need it, and not really become someone's lifeline or clinician in a your role isn't as a clinician for your team members. I would constantly have the EAP information ready. You know, I think it's always best if you say, hey, look, here's an EAP. I'll never know if you call or not, but I just want you to have access to it. I would utilize those types of things a lot if I saw somebody having stress and, hey, it just seems like you're stressed. I make these referrals a lot. But if you ever have adverse outcomes or a particularly bad intervention or something that was traumatic that somebody saw out in the field, there may be times where you want to help them process through that and just kind of talk about what their thoughts and feelings and so forth may be. But there's going to be times where you want that to go through the EAP for just to separate that boundary issue a little bit more and have your staff safe. One thing I've seen in a lot of teams is supervisors have done their time on a mobile team and they move up into supervision and they don't like going out in the field. Basically, I would spend a lot of time making sure my supervisors were going out with the teams. I want them to see what the teams are doing, make sure that there's quality there. But also, if they're my best and brightest and moved up into a supervisor role because they were really good on teams, I want other people to see how they work as well. One thing I'm going to skip here is, and then come back, is you need a vibrant pool staff. So when we're starting to budget what it costs to run mobile teams, always try to start budgeting in. I need to have a good pool staff. I need to be able to make sure that my staff have the ability to take days off. If you don't have a vibrant pool staff, your folks are not getting the days off they need. They're not getting the break that they need. They will start leaving. And every time someone leaves, that hiring and training cycle is going to put you behind the 8 ball. So what I would end up doing is I would hire a vibrant pool staff. And I know the one way to keep pool staff is to give them the hours they need. If I've got a pool staff and I'm going to use them for 2 months, they're no longer pool staff. They're going to go work at an inpatient facility on pool where they can get their 24 hours or 40 hours a month that they're looking for. So I really need to make sure that my pool staff are getting utilized. So what I would do is I would bring pool staff in on a regularly scheduled basis as well, and just go ahead and maybe have a 3-person team for that day, so that I do have my clinician or my peer. They're part of the team, but they're not taking quite that heavy burden. Or I'm giving them a training day where they're getting through all of their Relias or their training episodes for that, or I'm sending to an outside training, or I'm finding a way to go ahead and utilize them in, helping redesign some of the forms that we're going to go ahead and use. But really what I like to be able to do is once or twice a month even, have my staff quote unquote working, but not working on a team. One way that I have found that really does energize is if I say, hey, look, today we're going to put Bill on your team, and I'm going to go move you over to team 2. And I just want you to go ahead and be that 3rd person. And then when we come back, we're going to talk about it a little bit. It's increasing a little bit of the trust that we have that you're going to be with another team, and maybe you can support them or they can learn from you. But it gives people a little bit of a change from the day in, day out grind. I do want to talk a little bit about how you manage with the key performance indicators. So in the first part of we've done, this is our second in a series, but in the first one, we talked a little bit about key performance indicators. These are the key performance indicators that typically I think you need to be keeping an eye on as a manager, as a director, somebody who's got operational control over mobile teams. What I had mentioned, and I kind of jumped over in the last slide, is I need to look at the data. I use the data to evaluate where folks are at, but I never look at a short time frame. You can have a bad day or a bad week. You might see a lot of folks with high acuity or low acuity, or there might be a lot of weirdness. I generally start taking a look at staff outcomes, usually on a monthly basis. And I may take a look at 2 months just to go ahead and see if there's trending one way or the other. But these are the indicators that I take a look at. So community stabilization rates for us is how many times do I go in the field, see somebody, and then keep them in community. Don't take them to an ED, don't take them to an inpatient psych hospital, but I'm able to keep them in community with the wraparound resources that we need. Now, if I'm seeing everybody, every time, anywhere, the reality is between 70 or 80% is a pretty good community stabilization rate. It means I'm seeing people who are drunk, probably a little bit more likelihood that they might need to go into a facility. I'm seeing people that are angry and agitated, someone else called for, might be a little bit more likely that I'm going to need to take them to a facility. But usually between 70 and 80% is a good community stabilization rate for an agency that has good community resources to refer people to. But what we do tend to see is that in Maricopa County, 10 years ago, that number was 70%, was as high as we would get. This year, it's 80%. We've gotten better by about 1% a year. And I think that is because, that the teams are a little bit more veteran, we kind of got our things down. But we've really developed more resources in the community. It gives teams a little bit more options. So I'm going to look at community stabilization rates. If over the course of 2 or 3 months, I've got one team that's stabilizing 80%, one team that's stabilizing 70%, it's probably significant after 3 months, probably not significant in any one given month, but somebody's more likely to go ahead and refer inpatient than not. And I need to think about, is the team A with 80%, are they not referring when they need to, or is team B referring when they shouldn't? I've got to start looking a little further into that. Involuntary commitment rates, send anybody, anytime, anywhere. There's going to be some folks that you need to start paperwork on, put them on an involuntary hold. I want to know what that number is as well. Average time on scene. So if I've got a team member that average time on scene is 100 minutes, 105 minutes, and another that is 75 minutes, I know 75 to 90 minutes is probably about the right time based on just how long I've been doing it and what the numbers tend to be. I may need to talk to that team that's spending 110 minutes. Average response time is important. From the time the call comes in that they need to roll, What's their average time to get on scene? Because what you will see is that teams will be in a crisis and they'll take, we talk about 4 out the door, which means you got 4 minutes from the time the call gets in to the time you're in the van rolling. But we'll see some folks that might take 7 or 8 minutes. They go to the bathroom to get their paperwork organized after the call comes in. Or what we'll see is they'll stop at QT and get a soda on the way. So I want to really monitor what their average response time is. Once again, in aggregate over the course of a month, should all work out. And what's the average police department co-response events? So at any given time in Maricopa County, a mobile team can say, I don't feel safe going to this call. I would like police to join me. And what I do know is that's about 3% of the time. That's what that number is. But over the course of 2 months, if I've got a mobile team that is at 6%, 7%, I'm going to start to say that's probably an outlier at this point in aggregate in 2 months. Let me go start taking a look through those situations. Let me see if I see some common denominators. I'm going to start talking with those staff a little bit to see what's going on. And what I have seen is some people will say, well, anytime I'm going out to a call and the person I know has a diagnosis of schizophrenia, for example, I know there's a potential for violence and I'm going to go ahead and call police. So is that really what that means? Where did you kind of hear that? Can we talk through that? Or I do know some staff that, quite frankly, anytime it's dark, they're increasing their calls for police because the darkness just seems to get them a little bit scared. So I'm looking at those that are outliers and that they're calling police too much. What I do want to caution you, though, is you have to look at the exact opposite. Once again, about 3% of calls should probably have a police co-response model if we just look at Maricopa County data for the last 10 years. So what do I do if I have a team that hasn't called for a police co-response in 3 months? Probably got a problem there too. They probably aren't calling enough. They think that they're cowboys, they can handle anything. And quite frankly, that's a little bit of a cause of concern for me as well, because I do know that there are going to be those situations that are dangerous. I don't want you putting yourself needlessly in a dangerous situation just because you think you can handle anything. So these are all of those things that we do tend to go into. So I want to talk a little bit about the performance indicators and the fears that I have around this, because here's something that I see. I'm going to say I see veteran directors do this as well, is they'll take somebody's aggregate data and they will start to talk to staff about it as if there is a problem immediately. So let's talk about community stabilization rates. Here's my biggest fear. If I've got somebody who is community stabilizing, let's say 60%, and I know my company average is 75%, on some level, I know, you know, that they're probably putting too many people in emergency departments or inpatient psych hospitals, probably. But the second I start to make their job performance about that particular number, you really should be getting 75%, Jamie. The second I do that, if there's an adverse outcome, and they say the reason I kept this guy in community is because my numbers weren't that good and I needed to get my numbers where they were supposed to be because I was in trouble for not getting the numbers that I was supposed to have. I'm in a significant amount of trouble. I need to break these aggregate data down to specific. Are we doing what's best for each individual person? Because what you do tend to see, data that you collect, you tend to manage. That becomes what the culture is. So if the culture is all about my community stabilization rate, I'm going to get my community stabilization rate where it needs to be. Whether that's right or wrong for the person that's in front of me, I'm going to get my numbers where I need to be. So what I'm going to encourage you to do as directors is find that dynamic tension between who's maybe not getting the key performance indicators that we would think that they should be getting and what's the causes for that. But then I need to take it down onto a very micro level and take a look at each intervention. If I'm doing what I'm supposed to do, the numbers will come through on their own. So I really want to talk a little bit about when you're using data to go ahead and drive management, it should give you some indications of what potentially is happening, but I can never go ahead and say I'm managing exclusively the data. I still need to bring it back to that person. So we're gonna go ahead and we're gonna do another one of these sessions. My understanding is that a date to be determined. I'll let Dr. Ramirez talk a little bit more about that. But one of the things that RI is good at is peer employment training. We've taught over 14, close to 15,000 people what they need to do in order to get certified by the state. We are allowed to go ahead and do peer employment training in California, but as an agency with about 1,500 employees totally across the country, across three countries, about half of our staff are certified peer support specialists. So we certainly understand that. We do talk about full fidelity of the model as incorporating peers. So we're going to talk a lot more about the role of peers on mobile crisis outreach teams. Talk a little bit about how to have a ladder for peer support so that you can go ahead and encourage professional development and growth. And then we're going to just discuss a little bit about workforce development in general, because as I said, your training period may be 2.5 months, but they'll leave and give you either no notice, 2 weeks, or a month. So you really need to understand how to be developing your workforce and how to kind of keep that vibrant pool going. We're going to do that in a little bit more detail next time we meet. So at this point, I'm going to turn it back to Eliana if she wants to jump in and kind of moderate the end, and we'll see if there's any questions.
Thank you, Jamie. That was phenomenal. I learned so much every time that I listen to you present. I learn a great deal and am bubbling over with questions. So while I'll start us off with the first question, if anyone else has questions they'd like to put in the chat box, please do. Jamie, I wonder if you could talk a little bit about what you're hearing and seeing in the field regarding mobile crisis outreach and COVID and the pandemic, and any places. You mentioned a little bit before about considerations being out in the field, and you talked certainly about safety. I wonder if there's anything else you might add as people are emergency responders and essential workforce.
I think essential is a good question. So I think there's multiple ways that we can go ahead and look at it. So I'm going to take a long walk on a pier that really should be short here. So one of the things that we know in behavioral healthcare is we've significantly undervalued our contributions to healthcare in general. And I'll say how I know that is evidenced. In 1995, I was in private practice. I was like 24 years old. I was a young man, but I had a clinical degree. I was certified as a counselor. I should be in private practice. At that point, insurance companies were paying about $75 to $85 an hour for a certified professional counselor in Arizona at that point. About 10 years ago, I went back into private practice. You know, counselor crisis work can be tiring. I went back into private practice. At that point, insurance companies were now paying $55 a session for this. And I sat there and I started to think, okay, that's about a 30, 40% drop in pay for a professional-led intervention over the course of decades. I don't know any other professions that do that, but on some level, I think behavioral health has always relegated itself to a secondary role to physical health. You know, on evidence-based practice, they taught me 9 theories of personality when I was in counseling school. They're not teaching 9 theories of oncology. You know, it's a little bit more in fact. And then I started thinking about me in private practice. If someone said, Jamie, I can give you $5 for a session, I'd go ahead and take it, a sliding scale. So on some level, what we've done is we've always kind of said to ourselves, what we're doing may not be as important as other physical health. And I think the world has looked at it that way. And that's a harsh thing to say. But where it became evident for me as well is during COVID. So what I'm telling you is that mobile teams should be a professional discipline. They are an essential service. They are a first responder that should see anybody, anytime, anywhere. But what did we see nationwide when COVID started to kick in? We saw mobile teams shutting down, saying, we can't go out there and do that. I can't play both sides. I can't say that crisis services is important, the mobile team is important, that it's an essential service, that it has to be there to support the community, and say that I can shut it down for 12 months just because it's going to be difficult to go ahead and do. So in Maricopa County and in Georgia, which you're seeing the exemplars, leaned into it and said, we understand it's going to be difficult. We need to have the personal protective equipment. We need to have our policies in place. But if we want to be seen as a professional trade like fire department, like ambulance, like police, if we want to be the ones that are in the field making the decision for those folks that are in behavioral health crisis and taking that lead position, we need to go ahead and do that. The second I say we're not going to do that, we'll let police do that. We'll let ambulance do that. We'll let fire go ahead and do that. We're not going to do that. Once again, we're relegating ourselves to the service that we provide is not where it needs to be. So for us to be able to move forward, particularly in COVID, those are the opportunities for us to step into it and stand into it. Now, it's not easy. Getting personal protective equipment last April, you guys all know how difficult that was going to go ahead and be. Creating policies and procedures, working with people with mental health issues that refuse to wear masks, but you're there, trying to be in confined spaces. But the reality is it's a pandemic. Healthcare couldn't shut down emergency departments. You've got to go ahead and respond. You've got to step up. And what I did see is those agencies that did that, the staff that did that, took on personal pride about the work they did. They understood the importance of the work they did, and they've gotten through it. So I think COVID was a good indicator that if we really want a seat at the table as behavioral health and substance use professionals, if we really want to divert behavioral health away from other first responders to a much more focused and precise kind of methodology, Those are the things that we need to do. So I know I got a little bit on the soapbox there, but what would drive me absolutely out of my mind, Dr. Ramirez, is when mobile team said, we'll come back in 6 months and see where we're at. And then when they came back and said, we think that we can do it now, they wanted to be treated with the respect that other folks that were working in that field the entire time is. We can't have it both ways. You either lean into it and say we're essential, or you give up and say we're not essential, we're nice to have. Being essential is important.
Jamie, this is outstanding. Thank you so much. And I'm tracking that we have 2 questions. We are at 3:59. So what I would like to do is share these questions with you, Jamie, offline, and we can send you responses in our follow-up email. So that way you have enough time to give good responses, and we won't move it all in here at this moment. So I just want to say thank you so much on behalf of everyone who is in this session and the future audiences who will watch this when it's posted on our website. Let's go to the next slide, please. We do have some upcoming learning opportunities, as Jamie mentioned. This Friday, we've got HIPAA ethics and professional boundaries, which is one of the topic areas that Jamie mentioned earlier that are critical to mobile crisis team trainings. We also have a session on self-care and compassion fatigue, another topic that Jamie mentioned. Next week, we're going to be screening the S Word, which is a documentary about people who have experienced suicide, both people who have survived suicide as well as family members to folks who have passed. We really appreciate you attending. Ayana has put into the chat box a link for our feedback survey. Please do take a moment to answer those questions. It just takes a couple of minutes and it helps us to figure out what's worked and what we can improve in the future. And once you complete the survey, if you would like to request CEUs, you will have the ability to do so. We will also send you a certificate of completion following this session. This should be arriving in your inbox in about 3 weeks. If you don't receive it, please do feel free to reach out to us at caremhsainfo@cars-rp.org. And finally, we do hope you'll stay in touch. Visit us through our website, social media accounts. Feel free to email us, give us a phone call, and connect through our newsletter. Without further ado, I can't thank you enough, Jamie, for your presentation today. We really are looking forward to that 3rd session in this 3-part series on mobile crisis teams. The 3rd session that will be coming up is around peer specialists in the workforce. And we will be announcing that date in our newsletter. So please do be connected to us. On behalf of everyone who's here, thank you so much, Jamie, and we will send those questions to you and follow up in an email. Thank you to all for your work. Have a great day.